Three, two, one. Recording is started.
So we welcome you all today for another masterclass by Dr. Abha ma'am on when and whom should we test for tuberculosis in infertile women. This topic is very close to her heart as she has fought over many years to dispel the myths surrounding suspicion and diagnosis of TB in infertile women. So over to you, ma'am.
Thank you, Bhavani. And you truly said that this topic is so close to my heart. I fought against two things. One was the advocacy of torch in recurrent miscarriage, and the second was the advocacy of ATT for any woman who failed to get pregnant. So let us see that in infertile women, when does tuberculosis, say if a patient has sarcoidosis, you will refer her to a physician. If a patient has meningitis, you will refer them to them. If a patient has any other problem of the liver or kidney, you will refer. But why tuberculosis has become it's a medicine topic. It is to be treated by either a physician or a chest physician, and if it is of a particular organ, by that particular person. But why should infertile women go through ATT treatment? So what I want to tell you is when and whom should we test for tuberculosis in infertile women, and if proven to have the disease, should definitely be treated. So when we see a patient, there are 4 things which we assess when she comes for infertility to us. We look at her ovulation and we confirm it. We look at the uterus, ovary, ultrasound. We look at the tubal patency. So the uterus, ovary, and ultrasound constitutes the 2 solid organs, which is uterus and ovary, and the other organ, which is tubes, is confirmed by a HSG. And the last, we would look at the male partner and see for semen analysis. And if we don't find a problem anywhere here, we would not think of any disease. Why would we think that this patient has some disease of the genital tract, and that is why every investigation is normal, but we should look for that disease? No. Reach approximate diagnosis for cause of infertility, look at ovulatory factor, look at male factor, look at uterus, ovaries, and peritoneal factor through ultrasound or whatever, and tubal factor. And if nothing is there, then you say this is unexplained infertility. Somewhere down the line where fertilization, the egg pickup happens, fertilization happens, the formation of a blastocyst happens inside the body, somewhere around the line, it stops at a particular place, and hence a pregnancy is not happening. So when you get a anatomical factor, say the uterus, ovary, and peritoneal factor or tubal factor, this is where the thought of tuberculosis as one of the reasons which is not letting the woman conceive arises. In that, other things which arises is maybe endometriosis, maybe adenomyosis, maybe old pelvic infections which are non-tuberculous in nature and have affected the tubes. Anything could be the reason. So how does tuberculosis cause infertility? We first need to identify this, that if there is tuberculosis in the body, how will it lead to infertility? Active TB disease in the body does not prevent pregnancy. So if a lady has pulmonary coughs, you can still find her pregnant. And all of us saw in our medical colleges where women from the lower socioeconomic strata come. They could be pregnant, nicely pregnant, and yet have active tuberculosis in their lungs. So all I want to say is even multiplication of TB bacteria inside the body do not prevent a pregnancy from happening. And another thing is that active TB disease of the genital tract with partial tubal damage can lead to ectopic pregnancy. So TB inside the tube, and still it doesn't prevent a pregnancy from happening. So happening of pregnancy is not related to the presence of even active TB, leave alone latent TB. So having said that, presence of TB bacteria in the body in any form, active or latent, do not prevent pregnancy or cause infertility till the tubes or uterus, the lining of the uterus, is damaged. You know how many microbes we have on our body? A TED presentation from Jessica Green explained the important role of microbes plays in our everyday lives. Average human has over 100 trillion microbes in and over their body. Now, if you think all these microbes are there, and a PCR test can pick up 1 to 10 microbes of the same group and amplify the DNA and show, oh, you have leprosy, you have tuberculosis, you have shigellosis, anything. So these microbes are there. The pathogenic one are only known when that type of microbe multiplies, damages the organ, causes inflammation, and leads to disease. So they can be present on our body always. So no microbial infection is treated till the microbe starts growing and show their presence in form of disease, may it be tuberculosis or leprosy. So when do I think of genital tuberculosis as a cause of infertility? I'm talking about myself. When do I think? One is that I find that there is a very strong family history of TB or ATT or past history of TB or ATT in the patient. And she's from a low socioeconomic background and has poor living conditions. And I find a tubal factor there. Then I find a tubal factor and then I look at her family history. I see on HSG her tubes are blocked, one tube is blocked, both are blocked. On an ultrasound, the uterus is retroverted fixed. And I think, oh, she has a family history. Her father or husband is suffering from TB. Or she did have TB in the past and she took ATT for that. And that TB was of the lung. And she also belongs to low socioeconomic background, poor living conditions. Or on physical examination, apart from these blocked tubes or whatever I found on ultrasound and HSG, I find lymphadenopathy at any site of the body. It could be mediastinal lymph node, pulmonary or abdominal, bones, joints, skin, external genitalia, vulva, vagina, cervical, anywhere. I find lymphadenopathy or a ulcer at any side of the body or a node like mediastinal node inside the chest and anywhere else. Or I do a pelvic bimanual examination and I say, oh, the uterus is retroverted fixed. There is no mobility. And there is a tubovarian mass also, which I can feel. Whether there is tenderness or not, I don't know, but it is there. Then I do ultrasound and I find truly a tubovarian mass or cyst or even encysted fluid in the pelvis, hydrosalpinx, in absence of previous pelvic surgery. This is so important. Today, I got a patient who had a surgery for endometriosis. The endometriotic cyst was removed. And over the years, 3 years passed, she couldn't conceive. And now she shows a cyst, adherent ovary, and a hydrosalpinx of 8 millimeter. She was told to have another laparoscopy to confirm tuberculosis and take ATT. Now, you understand that once the tube will get stuck and this is proven endometriosis, then it has to be hydrosalpinx as a result of tube getting stuck. So it has to be in absence of previous surgery. If you find such masses, think of tuberculosis. And on HSG, when you find mid or distal tubal blocks, not cornual blocks, retort-shaped or lead pipe appearance on HSG or proximal tubal blocks with positive ultrasound findings. If you find a proximal tubal block and you have ultrasound findings of TO masses, sure, it could be tuberculosis. But otherwise, if you don't have anything on ultrasound and you have mid or distal tubal block, then either it is a poorly done HSG, and if it is a true block, it could indicate a tubal disease, out of which tuberculosis is one of them. Having said that, why there is so much of diagnostic dilemma for genital TB? I'll tell you why. One is that endometrium is most easily accessible for investigation. Tubes are very difficult to get. And on the other hand, only 50% cases of genital TB involves endometrium, when 90 to 100% of fallopian tubes are already involved. So we would only get access to those 50% of cases where the TB bacteria have extended to the endometrium, yet it is a paucibacillary infection in the genital tract because these bacteria require high oxygen tension to grow, as is available in lungs. So it grows much more readily in lungs rather than in genital tract. Another thing is monthly shedding of endometrium happens. So it tends to shed off unless the multiplication is not to an extent that it permanently goes on involving the endometrium. it may not be able to stay in the endometrium. So we have to rely on a combination of findings or use an algorithmic approach to diagnose these cases by thorough history, systematic clinical examination, intensive investigations, and high degree of clinical suspicion. So it is very important to have high degree. Just a HSG corneal block is not high degree of clinical suspicion. It has to be there with a bimanual pelvic examination by a ultrasound, which shows some findings somewhere. Tubes are normally not seen, but if you see tubes on ultrasound, that means they are thicker, they are, they could be filled with fluid, or they could be filled with any type of fluid, caseous material, anything like that. So the diagnostic dilemma is there because the endometrium sheds, and only 50% of cases involves endometrium. So when you have a suspicious case, what are the screening tests you would do? Start from a CBC, ESR. Skin testing is Montague's test. IGRA is interferon gamma release assay or quantiferon gold. Very surprisingly, I heard a quantiferon diamond also, but I don't know what that test is. I asked my microbiologist and I didn't know what is quantiferon diamond. Then radiology, X-ray test for mediastinal nodes or primary complex. Please write this to your radiology that look at the mediastinum for a primary complex or mediastinal lymph nodes. And apart from that, HSG and ultrasound. So what are the confirmatory tests for tuberculosis? You have to do a laparoscopy, hysteroscopy, because the tubes are the first thing to be involved in genital tuberculosis. You cannot diagnose till you've seen the tubes. Another thing is you do a biopsy and the histopathology confirms that, yes, this is tuberculous. This lesion is tuberculous. Then you do a bacteriological examination where just AFB staining, Nielsen staining, and then you put them to culture, whether it is rapid culture or normal culture. You see TB bacteria grow so slowly that it takes 6 to 8 weeks for the culture to show the TB bacteria. The rapid cultures now show this much faster. And then comes the molecular in conjunction with endoscopy. Don't forget this word. Alone, PCR and gene expert have no value unless you have a clinical suspicion, you have suspicion on investigations, and the confirmatory test has to be on endoscopy with molecular test like PCR or gene expert. Now, how do I confirm tuberculosis? Positive pelvic findings on examination, USG or HSG. What do? I will have to convince the patient through laparoscopy, hysteroscopy to confirm the diagnosis of genital cox. Don't take the treatment of ATT lightly. It is so difficult to take all those 4 drugs around breakfast, empty stomach, and patients just vomit across 4 or 5 hours after taking these medicines. It leads to extreme hepatic toxicity. I've seen patients being referred for liver transplant after just 15 days of ATT. So don't think that giving ATT for 6 months is like, oh, nothing, you've just prescribed the medicines. How difficult it is for the patient to take. You cannot give ATT across the day. You have to collectively give all the 4 medicines together within 2-3 hours, because they all sort of enhance each other's effect. They're not to be given at 8-hourly or 6-hourly differences. And it is very difficult for the patient to take 6 months of this medicine. Laparoscopy is just one day. It is good to put in a scope and see if there's evidence of tuberculosis in the pelvis or not. Number 2, if you cannot do laparohystro, there's something which just doesn't allow you to do it. Do a Montague's, do a IGRA, do a chest X-ray, endometrial biopsy for AFB staining culture, or do gene expert or PCR for TB. All this will assist you in the diagnosis of a suspicious case, that on HSG, you found the tubes had a mid-tubal block. You cannot do a laparohystro, then do all these tests. And if you find at least 2 positive tests, go ahead and think of tuberculosis. This is a paper from Professor J.B. Sharma, who is in All India Institute of Medical Sciences, and he has done a lot of work on tuberculosis. And he said that hysteroscopy with laparoscopy is the most reliable tool to genital TB. Like we say, this is not peritoneal. Subacute stages where we will find, infection is still happening, congestion, edema, pelvic adhesions, fluid-filled pockets. Say in endometriosis, also stage 1 and 2, you find flimsy adhesions. Here you find they are flimsy adhesions, but they are filled with fluid. Miliary tuberculosis or white, yellow, opaque plaques on uterus and tubes. Chronic stage, yellow nodules on tubes or beaded tubes, short swollen tubes with agglutinated fimbria, or bilateral hydrosalpinx, tobacco pouch appearance. The best is just cut the tube at that area and you will find caseous material jumping out of the tube. This is tuberculosis, whether the bacterial examination shows or the histopathology shows or not. This is tuberculosis if caseous material comes out when you incise a tube. And the last is adhesions, various type of adhesions. Maybe they're perihepatic adhesions. Now, this was very popular in our books when we said that, it happens in chlamydia, because in the Western countries, active tuberculosis does not happen. So they don't see that Fitzgerald type of adhesions over the liver in any other case apart from chlamydia. In our country, it is present in both the cases, in chlamydia also and in tuberculosis also. Then you might find various grades of pelvic adhesions and inability to see tubes due to adhesions in cystic ascites. And this is in patients where never any surgery has been done. And hence, you know that these are typical findings in tuberculosis. Now, all granulomas, caseous material are generally always tuberculosis, but granulomas, which you see with or without caseation, are not TB. They could be a granuloma, which is Walther's cell rest, very commonly seen as multiple granuloma-like structure on the tube. And one of my juniors asked me, why do you say this is not tuberculosis? I told her, okay, I took a nice broad peritoneal biopsy from there where I got 3-4 of those granulomas and sent it, and it was Walther's cell rest. Then there could be malignant deposits, there could be a foreign body, there could be idiopathic inflammatory conditions, infections such as fungal, syphilis, leprosy, pneumoconiosis, sarcoidosis could also lead to granulomatous deposits. And autoimmune lesions like rheumatoid arthritis, systemic lupus erythematosus could also have granular lesions over the tube. So please do not undertake any granular lesion as tuberculosis. Perihepatic, subdiaphragmatic adhesions, both in chlamydia and abdominopelvic tuberculosis, I just told you. So this is very, very diagnostic of tuberculosis in case you find tubal findings also. Even if your histopathology and bacterial analysis is negative, think of more tuberculosis in our country and less of chlamydia. So when should we consider doing screening tests for confirmation of genital TB leading to infertility? When do we do a screening test? In presence of tubal disease, such as singular tubal blocks confirmed by HSG or laparoscopy. Now, you've done a laparoscopy, you don't find anything else over there. You don't find caseation, you don't find granuloma, you don't find adhesions, maybe 1 or 2 simple adhesions here and there. And there is only one-sided tubal block. So you think, oh, this is mid-tubal block. Why is it there? On HSG, it was there. On laparoscopy, again, it is there. Then you do the screening test to support whether this is the starting of tuberculosis or not. If you don't do it, in 6 months of time, you will find both the tubes gone if it was tuberculosis. Then laparoscopy, if you find that, this patient already had TB, abdominal TB, or she was treated for some TB, but you find no granulomas or caseation in pelvis, then you know that whatever she had has cleared out. But you find fibrosis and adhesions. So you can take a biopsy from there. If it is culture negative of these fibrous structures, no ATT again. If it is culture positive, then you will treat it as drug-resistant TB, and we will not treat. We are not fit to treat this. We will have to send this patient to a TB specialist to give the second-line drug treatment to them. Third is high suspicion of TB on laparoscopy, never received ATT, and the culture and histopathology both are negative. The culture also doesn't show anything. Histopathology also doesn't show anything, but I feel, oh my goodness, this really looked like tuberculosis. There was so much of, adhesions, the tube looked all lead pipe-like. I sent a biopsy from the tube and they said no tuberculosis. I sent a culture from the peritoneal fluid and there's nothing. Here, post-operative screening test may help, and a Montoux, IGRA, or chest X-ray might give us an indication. If something is positive, give her ATT. So these are the patients where you have high suspicion of laparoscopy, have never received ATT, and do not show anything on culture histopathology, but your suspicion is very big. Here, one word of caution. A lot of people, when they see endometriosis, they cannot differentiate and they say, oh, there is TB with endometriosis, because you see a lot of blebs on the uterus, tubes in the peritoneal area, water-filled blebs, and they say there is endometriosis and there is superimposed tuberculosis. In such cases where endometriosis is there clear-cut, please wait for some bacteriological or histopathological report to say that there is TB along with endometriosis. These two are not commonly coexisting conditions, though endometriosis has a lot of adhesions, flimsy as well as strong, and does have blebs over the uterus and tubes. It is not tuberculosis unless proven by culture and histopathology. So diagnosis is on the basis of one culture positive specimen, and you say, yes, this is TB, I will do it. I will go ahead, whether it was on endometrium or on the tubes or on the peritoneal fluid. Positive histology, from wherever you picked up a biopsy, they say this is a granulomatous tuberculous lesion. 100% you will give ATT. And if you have a strong clinical evidence consistent with active genital TB, then you apply screening test. And if 2 screening tests are positive, go ahead and give ATT. What are the indirect screening tests for TB? Now, the only difficulty with these screening tests for TB is they cannot detect between latent, treated, and active tuberculosis, because they would be positive in latent also. They would be positive even after you've treated tuberculosis, and they would be positive in active tuberculosis. The main tests are Montoux test, which is tuberculin skin test, the TST, IGRA, the antigen detection test, which is DNA nucleic acid amplification, whether we do it by the polymerase chain reaction method or by gene expert. In gene expert, we can also see resistance to rifampicin also. So Montoux test, just one word about these tests. It could be falsely negative in immunocompromised patients, like those who have AIDS or are on steroid therapy or on chemotherapy, or have chronic illnesses like cirrhosis, renal failure, chronic, or malnutrition. They can be negative in typhoid fever, typhus, brucellosis, leprosy, pertussis. If the PPD used is old, is more than 2 days old or 3 days old, in what happens in a lot of labs, very few Montoux tests are ordered, and hence the tuberculin vial is there, which is old, 10 days old. So that becomes a poor standard of PPD use. And inappropriate injection, if it is given deeper than intradermal, you will not see the reaction. If it goes subcutaneous, you will not see the reaction. It has to be absolutely within the dermis. False positive you will get if the patient has received BCG. And you know what happens in our country, BCG is given to every neonate now. In my time, it was not given. So when I entered medical college, we all had mass radiography of the chest, MMR, that was known. And what was that? It was a small radiography where they would just see the mediastinum and they would look for a primary complex. If you had it, nothing. If you did not have it, a BCG vaccination was given at 17 years of age when we entered medical college. Then it can have a cross reaction with non-tuberculous mycobacterial infection. Mycobacterium could be specifically tuberculosis, or it could be the whole species of tuberculosis. There could be a booster phenomena also, which could lead to false positive result and subjectivity of interpretation. So TST is positive in 42% of genital TB, or I would say TST indicates latent TB infection. You will come to that later. And it will be positive in 40% of our patients, whether there is genital TB or there is not. There could be no genital TB. If we do in general population, if we just take a sample size of 100 from fertile, infertile people, we will still find Montoux test positive in 40% of people. IGRA positivity in endemic areas is again 36%, very close to 40%, because this is the rate of latent tuberculosis in our country. And diagnostic test for latent tuberculosis, it is a diagnostic test for latent tuberculosis used abroad a lot, but it can be used for people before we start immunosuppression to see if they have latent tuberculosis. Please give some treatment because we are going to suppress their immunity, and this latent tuberculosis may flare up during immunosuppression treatment. Or in HIV positive individuals, it is important to do. It cannot be used to monitor therapy because reversion rate after treatment varies from 0 to 72%. It may become negative, it may always remain positive. TB PCR is a very highly sensitive test, and this is the most common test used everywhere. People do it before doing a HSG, people doing it for every infertile patient who walks in. What is this? It is a rapid molecular method of identification of nucleic acid sequences specific to Mycobacterium tuberculosis and other mycobacterium in tissue samples of patients with genital TB. Detects genetic material from bacteria. Now, the bacteria could be dead or alive. The DNA is going to be there. And as little as 1 to 10 bacilli, the DNA which is released from 1 bacilli or up to 10 bacilli can be amplified by this method. So there is an extremely high false positive rate because this is a very, very sensitive test. And it can even pick up Mycobacterium tuberculosis DNA by contamination of specimen with environment, such as from work surface, tap water, vaginal perineal area, sample collection of menstrual blood. So I'll just give you an example. A gastroenterologist who's very famous sent 10 samples of the tap water with which we do our hand washing in the OT. It's supposed to be very clean water. And 10 samples of that to a lab, which is now closed, Oroprobe, only because of the very high positivity rate of PCR. And 7 samples showed a PCR positivity in the tap water sample. So this is the extent of how much it can pick up DNA, and mycobacterium is there in our air, in our water, on the surfaces, and so much so on vaginal perineal area and menstrual blood. Lab standardization, quality control is a major issue. 50% positive samples are seen in some labs. Now, labs are becoming careful. They are using tests which are very sensitive and specific for this, but still the positivity rate is quite high. So this is again G.B. Sharma's paper, A Diagnostic and Therapeutic Challenge. He said this is what tuberculosis is. So only used for a combined assessment when clinical suspicion of TB disease is high, but staining and cultures are negative, use TB PCR. Clinicians should not initiate ATT for patients only on the basis of positive PCR due to high false positivity and should correlate with clinical evidence of laparoscopic findings. Please read this article. I've also given the year. In 2014 and 15, he published so many articles because a lot of us, including me, were fighting against this ATT for all infertility patients. It does not indicate cure if negative or resistant tuberculosis if it is still positive, excuse me, after treatment. So you do a TB PCR and you give the ATT. And then after 6 months, you say, no, you don't need a PCR. Or if you do a PCR, it is still positive. What do you tell the patient? You say, no, now you don't need. You needed it only when the first time it was positive. Second time, it's okay. Ignore it. Can you do that? No. The patient will come to you and ask you. He'll go to 10 places and ask that I was given this treatment on this test and now this test is still positive. What do I do? Why? Because PCR has not been validated in fertile population in Indians. Like if we tell patients only have PCR positivity and those who've just got 2 children do not have, then we could say, oh, infertility is being caused by this PCR. So it has not been validated in fertile population, as we do not know how many fertile women are TB PCR positive in our country, which has a very high prevalence of the disease here. So what we did, this is our study, which is still unpublished. I did it with Dr. Niti. I was so aghast by seeing ATT being received by all infertile patients that here we did 44 cases in the infertile group. We used to do a lot of laparoscopies those days. Now we do only laparoscopies which are targeted for some surgical correction. But we used to do in the earlier days more laparoscopies to find out early endometriosis, everything. So what we did was we put in a laparoscope, and if the pelvis was clean and there was no other finding there, we took a TB PCR in the OT, which is the most sterile place to collect a TB PCR. On the other hand, ligation was prevalent in our hospital those days. So all women who came for ligation, we made it this thing that we used to do laparoscopic ligation, a clear pelvis, did the ligation and took a TB PCR from the uterus. And look what we found. Number of cases PCR positive were 88, which said the percentage was 18.18 and 16.16. So whether she was going in for ligation or she was infertile, the percentage of PCR positive from endometrium was the same. And here in the operation theater, under quite sterile conditions, more than what it is in the OPD when you take menstrual blood, we had collected these samples. Well, this paper never saw the light of publication because we couldn't write, or whatever reasons were there. This is Dr. Alka Kriplani's paper, published again in 2016, because those were the years we were very, very pained. And so since 2010, we all started working towards a lot of papers for this. And what did she say? Role of anti-tubercular treatment for positive endometrial aspirates. DNA PCR reproductive outcome in infertile patients in Indian setting, a randomized trial. She did a randomized trial. 100 endometrial TB PCR positive women were evaluated by laparoscopy, and they all had patent tubes and all other test negatives. So the sole test was positive, was TB PCR, and all went through a laparoscopy and everything was normal. So they divided them into two groups. 50 women received ATT and 50 women did not receive ATT. Pregnancies were seen over a year. Pregnancy in group 1, which means who received ATT, was 50%. In group 2 was 42%, not statistically significant. Repeat PCR positivity in non-pregnant women. It was again, when they did not get pregnant after 1 year, a repeat PCR positivity was done. 23 out of 25 were positive in the ones who received ATT, and 26 out of 29 were positive, those who did not receive ATT. So you look, that TB PCR thing would be positive whether they receive ATT or they don't receive. So what was her conclusion of the study? ATT for positive DNA PCR, not only. Only for positive DNA PCR, ATT is not justified. Repeat PCR testing after ATT is again not justified because it does not tell you the group who really needs ATT. Then this is my paper, which was published during COVID only. Prevalence of endometrial tuberculosis PCR positive in a population referred for in vitro fertilization in a developing country. I did it with Shruti, who was one of my fellows. And for this, I asked Dr. Ganguly, who's the doyen of research, to get me two TB PCR tests, one highly specific and one highly sensitive, to be applied in all patients who were undergoing IVF. We did an endometrial biopsy around day 20 of the previous cycle. And we told them that, we had to convince why are we doing it. So any patient who had received ATT or who was diagnosed with TB anywhere in the body, we took a TB PCR for all of them. And what did we find? The pregnancy rate was 33% in the PCR negative and 21% in the PCR positive, with no statistical significance. And pregnancy rate per started cycle was 28 and 26%. So if you see, PCR as a diagnostic modality promises to be highly specific, but should never be used in isolation to start or conclude drug treatment. As has been seen, patients who were PCR positive lacked any other sign of the disease and fared equally well with ART. A high clinical index of suspicion and combination of various diagnostic modalities must be kept in perspective to diagnose this highly enigmatic disease. So you understand that we took patients who were referred for IVF. Lot of them were already, they took ATT empirically, or because of whatever flimsy diagnosis were there, or because of PCR positivity, or they truly had TB. But they were referred only when the course was given or when they were treated for active disease, and then they came for IVF. And we took a TB PCR, and look at the PCR positive rate. It is so low. Out of 226 patients were PCR negative, and 19 were only PCR positive, because we used an extremely sensitive and specific test. It was not 10, 20, 30% like we find in general laboratories. So what is the new test? I did not discuss this. Gene Expert is almost similar to TB PCR only. This has been endorsed by WHO for worldwide usage that permits simultaneous detection of MTB complex and resistance to rifampicin in less than 2 hours. You get the report. So it is so good. Now, risk of contamination is very little, as the entire process is done in a closed automated system. So environmental pollution is very less likely. Our environment has heavy load of TB bacteria. Where is it heavier? In crowded places like cinema halls, aircrafts, prisons, schools. As with other nucleic acid amplification tests, Gene Expert assay should be interpreted along with clinical, radiographic, and other lab findings. You cannot use it alone like you use TB PCR. It is more expensive, so people still resort to PCR, and it is less available. This test does not replace the need for AFB smear with microscopy and culture for AFB and growth-based drug susceptibility testing. Further research is needed in identifying the role of Gene Expert in the diagnosis of female genital tuberculosis. Having said that, my take-home message is rely on algorithmic approach using multiple modalities to diagnose genital TB only in suspicious cases of tuboperitoneal and endometrial disease in women with infertility. So it is only these. No other unexplained infertility should be tested also for this. All blocked tubes and pelvic adhesions seen on laparoscopy are not tuberculosis. We need to confirm by histopathology, bacteriology, and strong visual evidence. You see, we find a tubal factor in the Western world also. But TB is not seen over there. They haven't seen TB in the whole lifetime. So there are a lot of polymicrobial infections which can lead to tubal blocks. So having a tubal block does not stamp the woman to have genital tuberculosis. Only TB PCR testing of endometrium as first-line investigation of infertile women is not recommended. Once a couple is diagnosed with unexplained infertility, does not warrant any screening test or other test for tuberculosis. Now, I'll just give you one or two things. Why do we look and treat for genital TB in our infertility patients? Because in unexplained infertility, we don't know what to do next. Month after month is passing. Maybe you've done IUI, so you just find a problem and you start giving ATT. At least 6 months or 9 months goes easily. Easy way out, want to give reasons to all infertile couples, find it difficult to convince the patient for endoscopy. And that is a routine. A lot of people say, oh, everyone does it, so I also do it. Why will I do what everyone does? I will do what my mind logically convinces me to do. And we can reassure the patient with treatment and its placebo effect. We can reassure, oh, you have TB, you take this, you will become all right. And if by the placebo effect, she gets pregnant within those 6 months, oh, see, you had TB, we gave you treatment and you got pregnant. If you don't give treatment, also Dr. Kriplani saw, you don't give treatment and still they got pregnant within the same stipulated time for people who did get pregnant and who did not get pregnant. I mean, who did not get ATT. Pregnancy rate was same in both. So even if you don't give anything and you give placebo instead of ATT, they will still get pregnant if things are all right. So I'll just give you one insight into it. TB bacteria are more in the environment than inside our body in a high prevalent country like India. Why do we say that we are a high prevalent country? Because we have a lot of prevalence of TB bacteria in the environment, which is air, water, surfaces. So for more than 40% Indians are exposed to the risk of TB disease due to latent TB bacteria inside our body, right? This TB bacteria also goes inside our body, and therefore we find that the Montague's test is positive. 100% of Indians are exposed to the risk of TB disease due to heavy load of TB bacteria outside our body environment. We are looking at this 40% which has gone in. Look at that 100% environment which has TB. And 5 to 10% of latent TB converts to TB disease in one's lifetime. From where does the remaining 90 to 95% come? It comes from the environment. So the environment gives us more chances of TB rather than what converts from latent to active. So what do we need to treat? Our body or the environment? We need to treat the environment. Air, water, indoor pollution, traditional cooking, tobacco, lack of sanitization, vehicles, fuels, factory waste, overcrowding, overcrowding, overcrowding. I would say everywhere where there is overcrowding and it is a closed space, there is the highest concentration of TB in the air. And if we take a DNA sample from this air, we will definitely grow TB. One or two words about just latent TB. Do I have the time? Should I go ahead or no?
Yes, ma'am, you can go ahead. There's a question also about latent TB from one
Okay.
of
So just
the
listen to this,
delegates.
and then that question may might. What is latent TB? Exposure to tuberculosis, but organism is dormant or inactive inside our body. Only 5 to 10% of latent TB will progress to active disease in a person's lifetime. Latent TB is a clinical condition defined by a positive Montague's test in people who have no clinical evidence of active disease. What is active TB? It occurs by active multiplication of the bacteria in our body to cause disease and tissue disruption. So, according to WHO, one third of the world's population has latent TB, which means people have been infected by TB bacteria but are not yet ill with the disease and cannot transmit the disease. This is very important. Most of these cases are in developing country. In India tops the list. India is the first out of the 8 countries which have this um, mm, tuberculosis in the world. The one-third population which has latent TB, and that India tops it. So what is the difference in latent infection and active disease? Latent tuberculosis, the TB bacteria enter us in humans and stimulates the immune system to stimulate cell-mediated immunity, after which it remains dormant as bacteria or its DNA and may have antibodies also. How do we cause latent tuberculosis? We try to cause latent tuberculosis by giving BCG vaccine or even by treated tuberculosis. Once we've treated tuberculosis, the antibodies have formed, the body has recognized the antigen. Primary infection is when TB bacteria enters from environment but remains dormant due to good immunity. So either it can happen as primary infection where no BCG was given in those days, or nowadays after BCG vaccine or after treated tuberculosis. How does active happen? Commonest mode is 90 to 95%. A big pellet of mycobacterium enters from environment to surpass my immunity. If it can be such a big pellet that when it multiplies, it will surpass my immunity, it will lead to tuberculosis. Or the pellet is going every day. You're living in an environment where there's a lot of TB in the environment. You are inhaling it with every breath. And one day the concentration and the multiplication will be so much that it will surpass my immunity. Less common mode is dormant bacteria in the body start multiplying due to lowered immunity and start active disease by damaging the cells and tissue. So why India is different when the question of treating latent tuberculosis arises? Why can't we follow Western countries in treating latent tuberculosis? Because the prevalence of latent tuberculosis is different in these two areas. High prevalent country, India is the highest prevalent country in the world, which means out of 2,000 people, 800 people have been exposed to TB and they have latent TB. So if we say our population is 1.2 billion, then 500 million individuals have latent TB, whether they are infertile or fertile, because our environment, air and water, is heavily polluted with TB bacteria. What is a low prevalent country? Like USA, European countries, where it is less than 0.5% per 2000. So we have 800 per 2000. Here it is 1 per 2000 of population. Whereas in a population of 400 million, only 2 lakh individuals in the whole country have latent tuberculosis. So what happens if we start treating latent TB, we will have to treat such a huge number. What was the number? 800 per 2000. More than 40% of people will be receiving ATT in our country. Because there is constant exposure to Mycobacterium tuberculosis in a high prevalent area like India, even after treating latent TB, the person may again get infected due to high concentration of the bacteria in environment, and this would mean repeated courses of chemoprophylaxis. Treatment of latent TB would only increase the logistic and financial burden on the healthcare system of the country, which at present is trying to cope with the drug demand for active cases. Our target for the eradication program is 2025. We've almost reached there. We are nowhere near eradication. WHO's target is to 2030. So let us see if we can reach there by 2030. So treatment of tuberculosis, the priority of TB control program in India is treatment of active disease. And testing and treating of latent TB is not recommended in India, as this is a high prevalent zone, unless an individual leaves the country for living in a low prevalent zone. And if latent TB is positive, there they will offer ATT to those people. My nephew went there. He got TB in Maulana Azad Medical College when he was working in the TB ward. He was treated over here. When he went to USA, his Montux was positive. First thing they said, you need ATT. But because he had he had already got treatment, they said the choice is yours. Whether you want to take a course again or don't, we leave it to you. You are a doctor. And he did not take it again. 90 to 95% of active TB in India occurs from environment, and 5 to 10% from conversion of latent TB only. So where there is low prevalence in developed country, the environment is clean. There is no TB in the air or bacteria, or if it is there, it is very thin in concentration. So all the cases are due to activation of latent TB infection because environment is not polluted. In such low prevalent country, treatment of latent TB is a major component of TB control, by which most of the active TB can be reduced in that country. So complications, I just want to bring your attention to this, that extreme drug resistant and total drug resistant is increasing in urban India due to indiscriminate use of ATT. Urban MDR is 51% and rural MDR is 2%. This was in the clinical infectious disease statistics of 2003. I don't know how much more has gone. India has the highest incidence burden of MDR, which is 1,35,000, followed by China, which is half of us. Its population is equal to us and it has half, and then Russia. Drug resistance occurs after treatment with ATT, whether it is given for latent or active TB. After a course of ATT for latent TB, if active disease happens, drug resistance is very common and it is very difficult to treat for the clinician and the patient. Second line ATT is now required for neonates and infants due to emerging MDR in them also. Long-term as well as fatal toxicity of ATT, liver failure is the commonest, which is requiring liver transplantation. So ATT is not to be taken as a simple drug. So, and facts about genital tuberculosis in northern India, at least I know because I stay here. Young healthy women on ATT on indirect test, approximately 30 to 40% of women are on ATT. Patients who come to my OPD one day when Neeti had joined me newly, she said, ma'am, can I make a register and see how many people have got ATT? Because every third patient who comes to your ATT is either receiving it or has already received it. And what are the tests? TB PCR menstrual blood. Now, how do you have it sterile? I mean, 3 trillion microorganisms are all over our body. How can this be free of it? ELISA has been abandoned now. It has been banned by the government. Montix or Q Gold, no test. Empirically also ATT is given. And faulty technique of HSG showing tubal corneal block, ATT is started. I'm just giving you my statistics. 500 to 600 laparoscopies are done under my care of urban infertile women attending Gangaram Hospital. Evidence of active genital TB on laprohistro is less than 2 to 3%. We do not treat more than 6 to 8%, if my statistics is right, in a year. All collectively, Shweta, Neeti, me, Ruma, I don't think more than 8 patients ever receive ATT in our hospital. So my plea to fellow clinician is these women are already labeled as infertile, with half of the couples infertile due to male factor, but the woman bears the brunt. We don't need to make infertility synonymous with tuberculosis only to justify a cause to infertility. Our next generation will face only resistant TB, and this disease will again become untreatable in India. as it was 100 years ago when they had no drugs to treat this disease. So please, please do not treat latent TB. Let the real TB disappear from our country. That is the need of the day. Thank you very much. Questions?
Dr. Preeti Mund wants to know when to take endometrial sample for gene.
Only when you have a very high suspicion, Preeti, that your tubes on HSG are blocked, or you find a sort of fixed uterus, or you find TO masses, you take an endometrial sample for gene expert if you cannot convince the patient for laparoscopy. I would not let anyone touch anyone I love with ATT till I have done a laparoscopy to prove that this is tuberculosis. Right now, I did a laparoscopy for large TO masses both sides, patient having fever since February. And when we did a culture and biopsy, there was no TB. It was just biosalpings due to polymicrobial infections.
Ma'am, I just wanted
She
to know
also
whether we should take it in the premenstrual phase, or like, because once the patient starts bleeding, so the endometrium will be shed off. So like in the premenstrual phase, should we take, or should we take in the follicular phase? That is what I wanted to ask. Like in the luteal phase, should we, premenstrual phase, we should
The
take it?
best time is to take in the luteal phase, and the best area to take is from the lateral walls, because TB comes from the tubes. And if the bacteria grow, they grow linearly first in the lateral walls. So if you have to take a biopsy, take it from both the lateral walls, take it in the luteal phase, but be careful that if the patient is going to be, her tubes are open and there is a chance she could be pregnant, then your endometrial biopsy may sort of minimize her chance to get pregnant.
Dr.
And ma'am,
Neeti
ma'am, what about in cases of thin endometrium? Like we don't get so much of like TB. मैम thin endometrium में कैसे करें, कुछ नहीं आ रहा
मुझे
है like
लगता है थिन एंडोमेट्रियम और थिन एंडोमेट्रियम दुनिया में होता है कि नहीं होता है वेस्टर्न वर्ल्ड में, ये बताओ पहले मुझे।
होता
खाली
है
थिन
मैम।
एंडोमेट्रियम इंडिया में है कि और जगह भी है? फर्स्ट आंसर दिस क्वेश्चन ऑफ
नहीं
माइंड।
है बाकी जगह पे भी
है ना? तो खाली
Yes
ट्यूबरक्लोसिस
ma'am, it
ही
is
क्यों है
all
रीजन
over
थिन
there. Yes
एंडोमेट्रियम?
ma'am.
Then why tuberculosis is a reason for thin endometrium? Look at any history. She had a abortion, she had a DNC, she had a hysteroscopy, she had a polypectomy, myomectomy, anything which she had in the past. Led to a thin endometrium. Definitely put in a scope, done, get the histopathology done. If it's just thin endometrium without any tuberculosis, then it is not tuberculosis. You don't give ATT.
Yes ma'am.
Dr. Neeti Vijay wants.
It is thick endometrium. I'll tell you, when you get a thick endometrium not responsive to progesterone treatment, these are the cases where I have found TB positive in a few cases, maybe 3, 4, 5 cases. Who can remember? I don't know, Neeti is not here, but she was with me when we did one patient who was just not responding. Endometrium would always come out 7, 8 on day 2. And right now I've done another biopsy for a patient who's not, sort of thinning out the endometrium on progestational agents. But here, a histopathologic diagnosis is very important. Please specify that you want endometritis tuberculosis to be ruled out, and also send a sample for, then you can send all 3. What I do, I send a slide examination, the fluorescent staining, the, what is it? What is the name? The
AFP staining?
AFB staining, a culture, and a gene expert. All 3 we get together when we send a sample.
Ma'am, should we send a endometrial sample for gene expert, or should we send a simple blood test for the gene expert?
No blood test. No blood test.
ठीक है ma'am.
It is endometrial sample only.
Okay ma'am. ठीक है ma'am. Thank you.
Any other questions?
Dr. Neeti Vijay is asking, she has a patient, her Montus is positive. She's 35 years old, has Asherman's, adnexal mass, and POI also. TB, PCR, and culture endometrium are negative. What should be done?
Oh, I think she's a very highly suspicious patient for tuberculosis, especially if she's never had any laparoscopy or any surgery earlier. Asherman's hai, adnexal cyst hai. Put in a laparoscope and just take a biopsy and just, sort of take a biopsy from a tube. She has adnexal cyst and masses. You will know what it is. And I think you should convince her for a laparoscopy, but this patient is a typical patient who could be having tuberculosis. And if her Montux is positive, do one more test, the screening test, do a IGRA or do a gene expert TB PCR under sterile conditions. And if that is positive, start ATT for her.
Ma'am, but TB PCR and culture was done, it was negative on the endometrium.
Laparoscopy, endometrium में बेटा 50% में आएगा. पहले tubes are being affected. So put in a laparoscope, convince her. And you have enough findings on a clinical examination to suggest TB. So please confirm it on a laparoscopy. I just now told you it is gold standard. JB Sharma wrote a whole paper which was published, said the gold standard is laparoscopy. If you can convince her for a laparoscopy, if you cannot, then Montux is positive and she has masses, you can give her the benefit of doubt and start ATT for her. But ideally, she should have a laparoscopy.
Okay. Ma'am, if we are not very clinically suspicious and there is this cyst, so cyst remove karna chahiye ya like what to be done for this adnexal cyst?
See, adnexal cyst, it is important to see what cyst is it, bache.
So it
You
should be.
know it is endometriotic. If it is endometriotic, hemorrhagic, you give her OC pills and it will reduce in 3 months, right? If it is hemorrhagic, it will reduce. If it is a simple cyst, it stays. It could be just a para-ovarian cyst or a tubal cyst. So the best way is, if it is bugging you and the patient, put in a scope. If it is not bugging you, you can ignore it. It is not increasing. It is clear cyst. Do nothing if it is a clear cyst. But if it has thick contents, it is good to put in a laparoscope.
And ma'am, remove it. If I'm suspicious of TB, shall I remove it or not? Remove it.
If you are suspicious of TB, you will send it for histopathology and culture also. You will take a peritoneal sample for culture. The moment you go in, don't do a hysteroscopy first in these cases. Go in with the laparoscope. If there's any fluid in the pouch of Douglas, aspirate it, send it for culture. Remove the cyst, send it for histopathology. You will know the answer. Histopathology will say simple cyst, forget everything. If it says it is tuberculous, start with ATT.
Thank you, ma'am. Thank you so much.
Dr. Priya wants to know, does TB have effect on the ovary or any correlation between TB and POI?
Yes, any chronic disease in the body, whether it is tuberculosis, and if it is even treated tuberculosis of the body, it lowers the ovarian reserve faster. So any prolonged illness like HBsAg positive, tuberculosis, HIV infections all lead to faster POI, and it also may have effect on the ovarian reserve, and sometimes they also have an effect on endometrial perfusion and lead to thin endometrium, but there's no TB. It is thin endometrium because she did have it and she received ATT for that. A lot of girls who don't have TB and receive ATT, they also end up with POI because ATT is a very, very strong combination of 4 microbials, which is given over 6 months. I don't know, in pregnancy, if a patient comes for an antibiotic use, don't your patients call you and ask, मुझे 2-3 हफ्ते का antibiotic लिखा है, मैं ले लूं कि नहीं लूं? मुझे टाइफाइड हो गया है, मैं लूं कि नहीं लूं? तुम ATT 6 महीने दे रहे हो और उनको बोल रहे हो प्रेग्नेंट भी होते रहो, इस बीच में प्रेग्नेंट हो गए तो भी you continue. Yes, if a patient becomes pregnant while taking ATT for genuine TB, we don't ask her to terminate because now streptomycin is not given. And if she's past the intense phase of treatment, which is the first 2 months, then she can definitely continue her pregnancy on whatever ATT. With a disclaimer that yes, we don't know what effect long-term could be on this baby, but there are no known effects which will affect the organogenesis of your baby. Normally, ATT we asked them not to try conceiving, did aspiration. So she was treated for miliary tuberculosis. It did not damage her tubes. She still got pregnant. And those were the days, her daughter is 31 years old. So she got pregnant 32 years ago when I had just started IUIs. There was no IVF still. So it did work for her. So any tuberculosis in the body, if it is treated and it has not damaged the tubes and the endometrium, the patient will get pregnant.
Dr. Priya wants to know if endometrial biopsy for histopath is positive for TB and we give her ATT, then should we repeat
Yes.
should we repeat endometrial biopsy after course of
100% yes. Yes. Very nice. If you get a biopsy positive, give her ATT and then look for it. And this time, if you get TB, then you treat it as resistant. And the course is 6 months. Very clear. I haven't discussed the treat. Medicines are to be given all within 3 hours in the morning. Maybe empty stomach, but patients are not able to tolerate it empty stomach. So maybe 2 before breakfast and 2 after breakfast. Number 2, they have to be given for 6 months. There is an intensive stage of treatment and a continuation phase of treatment. So you must know the doses per kg body weight and not just give a AKT tablet for a woman who's 50 kg or 80 kg or 90 kg alike. It is all different. Anything else? Okay, we conclude this.
Dr. Asima Khan is asking.
Yeah.
Dr. Asima Khan has asked about IVF success after TB treatment.
Maybe unstable connection. Seema? What is Seema asking for? Say again, Bhavani, your voice was cutting.
Okay, ma'am. Dr. Asima is asking about IVF success after TB treatment.
Very good. Very good. Maybe ovarian reserve is slightly low, but IVF success is equal. You've seen patients who had TB and who did not have, all fared equally well.
We are done with the questions, ma'am.
Okay. Thank you very much.
Thank you so much, ma'am.
I was thinking, I was expecting, are my fellows there? Are my fellows there? Where is Neha, Tanu, Nitika? Vijeta, are you all there?
Yes, ma'am.
Who? This was Tanu?
Yes,
Where is
ma'am.
Vijeta? Nitika, where are you? You all tell me every day, ma'am, take a lecture on TB, and today there's a lecture. If you don't hear it, I'm not going to take it again. Where are the others? Where is Neha?
Yes, ma'am. I am also here.
Who is this? Vijeta?
Vijeta.
Yes, ma'am.
Yeah, and where is Nitika? Nitisha? Nitisha and Neha are absent. Kal Viva hoga Neha and Nitisha ka on tuberculosis. We are going to have a Viva Vosi in the morning tomorrow of Neha and Nitisha. All right. Bye-bye. Good night.
Good night, ma'am.
Good night.